From Microbe TV, this is Infectious Disease Puscast episode 13, recorded on October 12, 2022. We almost didn't record tonight because I was sitting there on episode 12 waiting for everybody. Well, I'm Daniel Griffin, and now that I'm on the right episode, joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. And now on to the literature, shall we?
All right. Well, we'll start with viral, and I continue to encourage people to listen to the This Week in Virology clinical updates. But here we go. The article, Efficacy and Safety of Switching to dolutegravir lemivudine versus continuing a tenofovir alafenamide-based 3 or 4 drug regimen for maintenance of biological suppression in adults living with human immunodeficiency virus type 1. Results through week 144 from the phase 3 non-inferiority tango randomized trial. All right, I'm kind of done. That was really a long title. But this was published in CID. So just when we thought treating HIV was getting a little bit easier, it gets more complicated. You know, I was just on the wards with some of the trainees, the residents, the interns, the medical students, and we always had this line that, hey, it takes $3 to come to the party with treatment of HIV. But what we're realizing now is that once that viral load is suppressed, we may be able to safely drop down to a $2, a 2-drug regimen, as long as one of those medications has a high barrier to resistance, like dolutegravir. All right. So that's it for viral. Bacterial. The article, Antibiotic Combinations Reduce Staphylococcus aureus Clearance, published in Nature. So Staphylococcus aureus. Many have this idea that we might want to use combinations of antibiotics to avoid the development of resistance, or because we are trying to target all the possible pathogens when we start empiric therapy. Here, these investigators found that drug efficacy was reduced rather than increased as more drugs were combined. Concerningly, they reported that adding a beta-lactamase inhibitor, commonly used to potentiate treatment against beta-lactam resistant strains, can reduce rather than increase treatment efficacy.
I have a follow-up from, I think it was last week. The article, Less is More, a 7-day course of antibiotics is evidence-based treatment for Pseudomonas aeruginosa, ventilator-associated pneumonia. So this is published in CID in response to the article from last week. Really, the authors here wanted to emphasize the merits of the 2 major RCTs, the NUM-A and I adapalene trials, and argued for what they thought were flaws in the prior paper, in particular, how open label RCTs are susceptible to recurrence assessment or ascertainment bias against a short course. They had some comments about the lack of adjustment for differential time at risk bias, so part of the statistical analysis. And, some comments about not feeling like the prior evaluation looked at what would be considered clinically meaningful patient-centered outcomes, and then felt like, lastly, there was not as much consideration for the potential harms of longer courses of antibiotics as there could be. I did pull out this one quote. Given the lack of equipoise, no additional clinical benefit, and increased risk of harm with long course, it could be argued that it would not be clinically appropriate to conduct another trial or ethical to expose future trial patients to unnecessary and unsafe prolonged courses of antibiotics. So quite the debate. I encourage people to check out both sides and see where they land.
I have to say, Sarah, I was getting ready to go to ID week, but now having gone on the record that I often will use a longer than 7-day course, I feel like I've been accused of clinically inappropriate and unethical
They're gonna
treatment.
hunt you down.
I'm gonna get I mean, this could be unsafe for me. Well, it's nice to see how passionate people are
Yes.
about duration of antimicrobial therapy.
Yes.
All right. Cholera vaccine recommendations of the Advisory Committee on Immunization Practices 2022 was published in the MMWR. All right. So, cholera is an acute watery diarrheal disease primarily caused by toxigenic V. cholerae serogroup O1. It can be severe, rapidly fatal without treatment. Now, we've had issues with cholera outbreaks at a few of our FIMRIC, Foundation International Medical Relief of Children sites, such as Restauracion, on the Dominican Republic Haitian border, as well as Bududa in Uganda. I have to actually say, in Restauration, it was quite a challenge. No running water at the hospital. So here you are in an area where you might be seeing cholera, and you're basically walking through this basin with dilute bleach. That was part of our infection control. Now, the case fatality rate ranges from as high as 50% without treatment to less than 1% with what? Appropriate fluid replacement therapy. Antibiotics have been shown to shorten the duration of illness, but fluid replacement is really critical. An adjunct only as massive fluid replacement really is critical. So just sort of throwing that out there. All right. So, what do we do with vaccines? So, CBD 103 HGR is a single dose, live, attenuated oral cholera vaccine derived from V. cholera O1. So, in June 2016, the FDA approved CBD 103 HGR for the prevention of cholera caused by cholera in adults aged 18 through 64 years traveling to cholera affected areas. I've gotten mine. That tells you a little bit about my travel destinations. In December 2020, the FDA extended the approved use to include children and adolescents aged 2 to 17. This is the only cholera vaccine licensed in the US, and all of the ACIP recommendations focus on this formulation. So, the efficacy of the current formulation, I think this is something for people to be thinking about, against moderate or severe diarrhea, defined as, I love when they define this, cumulative fecal output of greater than 3 liters after oral toxigenic V. cholera experimental challenge in adults aged 18 through 45 years is estimated to be 90% at 10 days after vaccination, 80% at 3 months after vaccination. This is one of those human challenge trials that I'm okay with. Not that I would sign up. ACIP recommends cholera vaccine for travelers aged 2 to 64 years to any area of active cholera transmission. The details of how you get this medicine is very interesting, and I will share this as I have personally experienced this. For all recipients, dose preparation begins with reconstituting the buffer sachet in 100 milliliters of cold or room temperature purified, non carbonated, non flavored bottled or spring water. Tap water should not be used because it contains chlorine that can affect the viability of orally ingested live attenuated bacterial vaccines. To improve palatability, a large number of children and adolescents have had pure Via brand stevia, a plant based sweetener, added to the reconstituted vaccine.
Just a little bit of sweetness in there. My paper is from the Journal of Antimicrobial Chemotherapy entitled Frequency of Drug Induced Liver Injury in Children Receiving Anti-Staphylococcal Penicillins. Um, so, this took a look at two studies of oral flucloxacillin, two with IV methicillin, three with IV nafcillin, and four with IV oxacillin. They found that the mean onset of drug induced liver injury ranged from 7 to 19 days after starting antibiotics, and all episodes resolved within about 2 weeks after stopping the drug. The incidence overall of drug-induced liver injury in children was about 1 in 50,000 for oral flucloxacillin, and then 1 in 3 to 13 for one of the IV penicillin, so oxacillin, nafcillin, or methicillin. And so the authors were arguing that routine LFT monitoring is probably not required in children who are on low dose oral flucloxacillin, at least in this case, but continue to support routine LFT monitoring for IV medications, particularly in the first 7 days. But there are no major serious or long term liver injury. So I think people often have variable practice patterns on how often they'll check LFTs when we have patients on sort of longer term uh, oral medications. So this one is suggesting that maybe we don't have to do it quite so frequently, at least in the outpatient setting. Although I don't know that it helps us change anything for the patients who are in the hospital.
All right. Well, I thought you were going to use that acronym DILI. I really enjoy the acronym DILI, drug-induced liver injury.
it
Yes,
is a it is a good acronym.
add that to all my differentials. Noted transaminitis, DILI considered in the differential. All right. The article Detection of Treponemapallidum DNA during early syphilis stages in peripheral blood, oropharynx, anal rectum, and urine as a proxy for transmissibility was published in CID. So here we are 100 years after this pathogen was recognized, 1905, still struggling with what can often be a challenging agent to diagnose. Direct our listeners to the appropriate febrile episode. Here, they are using PCR, and for 50% participants with primary syphilis, uh, treponema pallidum, TP DNA, was detected in at least one study sample. Now, where did they find it? 3% peripheral blood, not very high, 10% pharyngeal, 19% anal, 34% urine samples. Now, for 85% of participants with secondary syphilis, the TPDNA was detected in at least one study sample. So, again, this time 21% in peripheral blood, 64% pharyngeal, 51% anal, 36% urine samples. Now, they reported this was very specific, but I actually am quite surprised at the low sensitivity in primary syphilis. Tells us a little bit about the disease. Now, we recently had a meeting of our infectious disease division. I was expecting it to be quite fruitful and productive, but productivity was low as the case of an octogenarian with a primary syphilitic chancre was discussed. I'm certain that one needed to be there to truly appreciate the story, or perhaps it was better not to be there.
Well, I have our lone fungal paper for this week. In JPIDS, the article is entitled Pediatric Pheohyphomycosis. Just trying not to mispronounce things. A 44-year systematic review of reported cases. And so, pheohyphomycosis is an infection, as some of you may know, caused by dematiaceous or pigmented fungi. We can have a pretty wide variety of clinical syndromes, from skin soft tissue infection to rhinosinusitis to more serious or disseminated infection. Uh, this paper took a look at proven invasive fungal disease in English and Spanish literature. They found that in the pediatric cases, the median age was about 8 years old. About 60% had some sort of underlying illness, which is kind of expected. The most common was hematologic malignancy, but there was a wide variety of other immunocompromised hosts. About 60% had localized infection, and the most common organisms were Exerohilum species, Exophiala, and Curvularia. And so the kind of main point is the prognosis in children seems a little bit better than adults. For disseminated infection, the mortality was about 37% versus about 80% in adults. And sort of the general mortality rate, I think, was about 20%. And then the other piece of this was how were they treated? And the children in this overall in the review, uh, I'm always curious when and how people use dual antifungal therapy, because it's a data light zone, at least for these, about 40 of the cases use some sort of combination therapy, usually ambisome plus vori or itraconazole. So just an interesting look. It's something we don't see that often, but I think it kind of depends on where you're practicing.
Yeah. I actually I'll say I had an interesting case this week. It was sort of the second visit. The things are all better of a case of chromoblastomycosis. So I always enjoy these interesting fungal
Is that
cases,
the copper
particularly
pennies one?
that is the copper penny one.
Yes. Yes.
Yeah. Yeah.
Studying for
Treated.
boards did something.
Yeah. You're all set. Treated with excision, and the individual's doing great.
Oh, that's awesome.
All right. Parasitic. We're sort of heavy this time on parasitic and miscellaneous. So
Yeah.
everyone take a deep breath. Be sure to listen to This Week in Parasitism. We have an unknown out there at the moment, and our next episode will be recorded at the American Society of Tropical Medicine and Hygiene meeting in Seattle. So a plug for that, early attendance right there at the beginning of November. So this article falls into the category of articles that I found entertaining. The article Association Between Toxoplasmosis and Bipolar Disorder, a systematic review and meta-analysis published in the Journal of Psychiatry. So these are the results of a review and meta-analysis of published articles obtained from a systematic search of PubMed, PsycInfo, Embase, and the Cochrane Library up to January 10th, 2021. I think it took them a while to get published. The search yielded 23 independent studies with a total of 12,690 participants, 4,021 with BD, bipolar disorder, 8,669 controls. So people with bipolar disorder had a greater odds of seropositivity with toxoplasmosis than controls, both in the fixed effects model, odds ratio 1.34, and the random effects model, odds ratio 1.69. Sara will be explaining those two models, but it left me wondering, is this true? Are bipolar people more likely to end up getting toxo? Are people with toxo more likely to end up getting bipolar? Does any of this really matter? Does any of it really
Mm.
make sense?
Yeah. Yeah. These are always a little hard to interpret. Well, guys, this is the one I'm most excited about because I think it was so interesting. There is a paper in CID entitled Nosocomial Malaria Transmissions Resolved by Genomic Analyses, a retrospective case report study in France, 2007 to 2021. And so they talked about 6 cases of autochthonous. Am I doing that right, Daniel?
You did. That was
I put
great.
dashes in for
Or
myself to make sure I said that
autochthonous.
correctly. Malaria cases in 6 different French
Mm.
hospitals, meaning that autochthonous biologically confirmed malaria when you haven't traveled to an endemic area in the 12 months prior to clinical onset. And so the usual quote story would be airport or luggage malaria, meaning there's a little mosquito that sneaks out and bites after you've returned. But there are other pathways of transmission, such as nosocomial. And so the patients in this case had no travel to endemic areas, no transfusions. And each of the paired cases had an overlap in time between the source and recipient where they were in the same ward. And although there wasn't a obvious, clear, quote, risky action, the authors generally speculated that this was something to do with contaminated medical supplies or equipment. And sort of particularly pointed to that because 4 of the 6 cases were in the setting of COVID, when we all know things in the hospital were slightly different. And so even though they were looking at a 15-year period, majority of them were sort of in that time frame. And so it's interesting, there's a combination of both pediatric and adult cases, and all the cases except one responded to artesunate therapy. And then they genetically showed that each pair of matched source and nosocomial parasite infections had less than 1% of different genome-wide short tandem repeats, and less than 6.9% of different single nucleotide polymorphisms. So just fascinating. And I was watching people talk about this on Twitter and say about how they had experienced cases like this that had not necessarily been published, but something that I definitely had not ever, I don't know that I've really thought about this before. And kudos to the people who were able to identify it ultimately, because that would rely on you actually getting a test to diagnose malaria, which you may or may not have been thinking about.
Yeah, I love this. I mean, you just thinking about it. So there you've got your source patient, and they've got malaria. They're getting bitten by a mosquito. And that mosquito's, female taking its blood meal. Now, for some reason, that mosquito is going to actually be one of the 1% rare female mosquitoes that's going to take a second blood meal, but it's going to do it with enough time that the malaria parasite is going to evolve to a form infecting that next person. So just when you just think about all the odds of this occurring in a hospital,
Yeah, it's
it's
fascinating.
amazing.
Yeah.
So, all right. I'm never going to be in the hospital in France. And if I am and there's mosquitoes flying around, I plan to complain. All right. Well, that was a fantastic article. And I have to say, this is my favorite article this week. The article, The Efficacy of Soap Against Schistosome Cercariae, a systematic review was published in PLOS NTD. Now, at one point, I joked about having a teenage son. And, at that point in life, they become allergic to soap. And I began to realize people are like, oh, I'm so sorry. I'm like, no, it's a joke. Anyway. So, some of our listeners who also follow This Week in Parasitism may remember the episode Towel Off Briskly. So, sometimes to enjoy my trips, I engage in magical thinking. So, when I swam in the schistosomiasis infested waters of Lake Malawi with my family, we followed Dixon Despommiers' advice to towel off briskly after swimming. Here, these investigators performed a review on studies looking at the efficacy of soap against schistosome cercariae. They only found 11 studies, lo and behold, that met the criteria to be included in this review. The review suggested that soap has the potential of protecting people against schistosome cercariae. And there are two protective aspects. One, soap affects the cercariae adversely. They don't like soap. Soap on the skin prevents the cercariae from penetrating the skin. They did suggest that we need more evidence to inform hygiene advice for people living in schistosomiasis endemic areas. I'm planning my next study now.
Yeah, that paper is very cool. All right. And then we have a couple miscellaneous papers. I have one, the article Recurrent ESBL E. coli Urosepsis in a Pediatric Renal Transplant Patient Treated with Antibiotics and Bacteriophage Therapy. So this is published in Pediatric Infectious Disease Journal. And the authors here talk about a 17-year-old female who initially had urosepsis from an ESBL E. coli and was on a pretty, somewhat aggressive immunosuppressant regimen because of rejection. And she had been admitted intermittently to the hospital for about 4 months and had 4 episodes of sepsis related to this ESBL E. coli infection and had gotten several courses of antibiotics, had even undergone a fecal material transplant to try to eradicate her ESBL E. coli colonized GI tract. But because of ongoing issues with these recurrent infections, she ultimately received treatment with a phage cocktail with 2 isolate specific phages. And so, after a prolonged antibiotic course and 3 weeks of IV phage treatment, she had no further ESBL E. coli in her cultures for several years after transplant. So, a super tough case, but I love reading the phage papers because I think it's fascinating, and hopefully we'll get to use this as a therapy for these tough multi-drug resistant infections in the future.
Okay. I don't know if you've ever read the book Aerosmith, Sarah, but
No.
Aerosmith in his later days retires to the rurals to investigate phage therapy. So
Oh.
bit of a throwback to, I think it was Sinclair or something who wrote that book. All right.
Okay, I'll look it up.
The article, After Action Review of the Response to an Outbreak of Lassa Fever in Sierra Leone 2019, Best Practices and Lessons Learned. Was also published in PLOS Neglected Tropical Diseases, one of my favorite journals. We always hear about how a bad job was done. What a bad job in infection control. But here we hear about a November 2019, an outbreak of Lassa fever that occurred among health workers in a non endemic district in Sierra Leone, where they actually did a good job. The outbreak resulted in 5 cases, including 2 that were exported to the Netherlands. In this case, once detected, the outbreak response contained the outbreak within 1 incubation period. Areas that worked well included coordination, contact tracing, active case search, and ring infection prevention and control practices. So, a nice article to read, a good bit of guide to doing things right.
Love it. All right. And I think I have our last paper. This one was also from CID. Demographic representation among speakers and program committee members at the ID Week conference, 2013 to 2021. And so the IDSA Board of Directors commissioned a gender disparity task force a couple years ago to try to help us avoid having so many manels or misbalanced speaker representation. And so this paper took a look at the changes. So women speakers increased from 39% to 58% from 2013 to 2021. White speakers decreased from 85% to 64%. And most of the sort of increases in speaker slots were filled by Asian speakers. The program committee members were largely, so over 80%, non-Hispanic white, with less than 5% identifying as Black, American Indian, Alaska Native, Native Hawaiian, Pacific Islander, or Hispanic. And so to sort of summarize what they were pointing out, gradual increase in women speakers. We still have an overrepresentation of white speakers relative to the membership proportions in IDSA. There has been a shift towards more international speakers. And then something that is very important has been shown in other settings. The proportion of women who are on program committees is associated with the proportion of women speakers. So if they help plan these sessions, we tend to have a better range and variety, including women speakers. And so there are some limitations, like thinking about more inclusive gender options and how the racial groupings are still quite aggregated. But I think important to think about. And I thought it's kind of a nice transition because ID Week will be next week, and hopefully we'll see some people there. But I am all for diversifying the speakers that we have at ID Week.
All right. And actually, I think this will be a bit of homework, right? So you're going to be at ID Week coming up. I think
Mhm.
you're also on the job search. So just heads up to anyone listening, looking for an outstanding person to join them. And then I'm going to be at the American Society of Tropical Medicine and Hygiene
Yeah.
meeting, so I can sort of look at the balance because I can't go to IDSA after I've now publicly stated that I engage in the unethical practice of treating Pseudomonas pneumonia for more than 7 days in certain circumstances. So,
Exactly.
okay.
Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions, so continue to send them to puscast@microbe.tv, and consider supporting the science shows of Microbe TV at microbe.tv/contribute.
I'm Sarah Dong. You can find me on Twitter at swindong, at Febrile Podcast, at febrilepodcast.com, or at ID Week this year.
Okay. And I am Daniel Griffin. You can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism, This Week in Virology Clinical Updates, and not at the ID Week meeting. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks.
Another podcast is infectious.